Um, I'm going to pose about 3 or 4 questions to the panel, and you can answer any one you want. There's a couple in my chat box here, and I'll read them out. From Tim Jones: do we believe that an improvement in the transition experience could improve outcomes for mental health? For example, supporting people in getting gainful, challenging and developmental employment. One question. A really straightforward question from Stephen Brooks: how will success in this service be measured? So, and I think, George, did you have a couple of questions that you picked up from people as well?
Yeah, I certainly did. Thanks, Kamlesh. Some people have just messaged me privately. So again, this is open to the whole panel, who I hope I've unmuted. But somebody has asked whether the speakers, Kate, I can see you shaking your head. I'll just do it now. I can see that somebody's asked whether some of the speakers could expand on how their work aligns with the military covenant, or if it even does indeed. Another one, and potentially this is for you, Kate. There's been a lot of talk about the work that we've been doing in Portsmouth, obviously, but how can these services be rolled out across the rest of the country? And one final question that I have personally, just for the panel, would be: COVID has meant that we've had to do an awful lot of things digitally. Do you think providing mental health services for this particular demographic digitally works, or are we suffering from not being able to engage in a face-to-face way? So Kate, I'll unmute you and I will open those questions up to the panel.
Okay, so there's the questions. Who fancies going first? Yeah. John, David, yeah.
Well, I'll just say on the employment one, absolutely. I mean, all that we saw that was so key to people's experience of trauma, but more importantly, their recovery and resilience to trauma. So much of that rests on the social side. That includes having a good job. And we know how key that is to people's successful transition out of the armed forces, going into civilian life, entirely new forms of employment, different work cultures. It's absolutely key that we've got that kind of employment support built into the overall service model, which I know is something that Walking with the Wounded do so well and have developed in various places around the country.
David?
Yeah, I absolutely agree with John, and thanks for your point, Tim. I think it's a really important aspect in people's enduring feeling of self-worth, and naturally, most people who've served in the forces are genuinely wanting to contribute and make a difference, and do a good thing and get that feeling of self-worth about it. So I think it is a really important element of this part, not necessarily exclusive, but a really important point. And I think one of the other questions was about the sort of the model, which Kate might want to come in and talk about. But certainly in our work in the southeast region of high intensity service, we're essentially we're working with our partners across the region in the southeast in terms of delivery of the model, and it's essentially trying to franchise what we've done really successfully in the Portsmouth space, upscale it and franchise it and roll it out across the region to try and replicate the success of that across the piece.
Is that a good point for you to come in, Kate?
Yeah, I'll try and combine some of the answers of all of the questions, but following through on the rollout across the country. I mean, I think one of the things we have to be careful about, and listening to Stephen as well, is kind of how we promote, if you like, the services, particularly the high intensity service, which is the focus on trauma, because in answer to the question, it is and always has been about rolling it out across the whole of the country. But in order to meet the financial requirement that we have to support this, which is significantly more than we've ever had before, but arguably we'd always like more, then it is about having a key provider trust that is the lead collaborative as has been outlined. And so I think we need to be really careful if we're talking about a Solent Trust or we're talking about another trust that has a name that's the lead provider, that it is about a wide brief as part of geographical self-referral and referral through the TILs and CTS and other mental health mechanisms. And I think there is something in the very early days, listening to the questions and the input, that we don't want to get that confused too early. That's an important one. And hence the name of the high intensity service, because we're trying to move it away from saying this is about Portsmouth, or this is about Bedfordshire, or this is about Birmingham. This is about the need that was so eloquently put together by both Stephen and John. I would say that, of course, we don't spend any public money without that being measured, back to the other question, whether that's about hard indicators on service delivery and provision, both in outputs, numbers, and also outcomes. But the most important thing, without a doubt, is the feedback from lived experience that say that they feel that there is absolutely that positive message when things go wrong, is that they feel that there is something that is there for them when it needs to be, and is flexible as well. And I think that that's one of the measures that we particularly put in alongside some hard indicators. And I'll just lastly go back to the transition element. We have also commissioned some great services like Step Into Health, which is about employment of armed forces personnel, particularly in the NHS space and other spaces. And I will go back to how we work with our integrated care systems with lots of people on a local basis to look at the art of the possible around housing, employment, and relationships. You know, kind of, I think the ambition there is there to be had, really. Thank you.
I'm just going to throw a couple of more questions in, because SJ and Maddie might want to do it, because it's really a couple of interesting questions from Annabelle and Tim again. Really good work. We'll be interested to hear views on early intervention and prevention while individuals are still serving. So I don't know if that's one for you, SJ, but when people are still serving. And volunteering. There's a perception that if you become a volunteer, that helps you as well. Would volunteering opportunities help through peer support networks? Do you want to have a go at that, SJ, for starters? And everybody. Unmute him, please, George.
Okay, perfect. Thank you. Yeah, I think it's a really good question, and actually it kind of plays into a theme that we've seen a bit more in recent years, which is where people leaving the service don't actually just leave outright. So it used to be that it was kind of you did your 22 and then you signed off and then you were gone. Whereas what happens now tends to be a bigger group of people. When they sign off, they're actually entering into the reserves. So they're still trying to keep that attachment to the military community and are almost kind of phasing themselves out of armed forces service. It's the same for people now leaving, and we hear more and more from people that are on their way out of the door and are already talking to us about volunteering opportunities and if there's anything that they can do to support our work and to support the military community. And it really is, I think, that brotherhood and sisterhood, that sense of camaraderie. The worry is that when you leave, you might lose that, and you'll lose those connections to the armed forces community. And it's important to a lot of people to actually maintain those connections and to make sure that they remain ingrained in that community. So I think volunteering will always have its place. I think good jobs have their place as well. So I'll explain a little bit more about what I mean by that. Is when you're in service and you're talking to someone down the pub and they say, so what do you do? Your chest puffs out a bit, your shoulders go back, you go, I'm in the army, I do this. It's a job to be proud of. It's a job you take pride in. Often people, especially if we look at infantry regiments or kind of lower level entry on education roles within the armed forces, when they leave, less so now than there was when I left, but then they may not have picked up many relevant qualifications to what they want to go into in Civvy Street, which means that they may have to go into more of an entry-level job within their new career prospects in order to get into the system. What that tends to mean is that you've got somebody that might be 30 plus years old working alongside people in their early 20s in similar roles, and you may lose that sense of pride, that sense of place. So what volunteering does is it gives you something outside of your vocation to focus your energy on and still have that sense of pride in, and still kind of puff your chest out and say that you do this. The amount of people that leave and get a job, so say I'm an office worker, but I used to be in the army, or I used to be in the navy. So they still add that, and they add that for years after they leave, because they still have that sense of pride about it. Anything that can make people proud of their transition, can still give them something to focus their energy on. I think that's a really positive thing to bear in mind.
That's really helpful, SJ. I want to ask Maddie one question just before we sort of end, because he said something very interesting about not making people relive their trauma constantly for the questions. How do you balance having a service user voice and the experiences, lived experiences, and making sure that's always at the heart of everything, with making sure people don't relive that trauma? It's a tough one, I think.
Yes, I think it's really, really important to have service users involved right from the get-go. We really found that from our experience a couple of years ago in Portsmouth in developing our model. I think there's something about the safety with which information is disclosed. If there is a good understanding of the context in which something is being communicated, how it's facilitated, how it's managed, and there is embedded support in place for, so one of the, I think, highlights from Trauma in Mind, for example, work we did with John, was ensuring that there was that support available for veterans who took part in producing this piece of work. So I think having access, immediate, rapid access to that support when, as a, possibly information is being disclosed that can be traumatizing, is going to be really important to get around that. Just a very quick point, Lord Patel, about the transition. I think it's really important to have DSEMH representatives within, so in our military mental health armed forces, we have, our alliance, we have DCMH representative, and in Portsmouth we're trying to work very closely to identify soon to be currently serving personnel to be veterans who are maybe at risk of potential difficulties, and have that handover as seamlessly as possible. I think is going to make a big difference.
That's really helpful. I'm gonna, time is a big issue, but I want the panel just to, and we'll try and get back to people maybe in some kind of note form. There's a very interesting comment from Robert Jackson, supported by Steve and Alexandra. If people can read that, maybe we can get some feedback. And also, Ian's asked again about the military covenant. We didn't touch on that. I don't know if you want to say something, Kate, about that as a last sort of few words. You got unmuted again, George. Our only chance to mute central leaders, you see. George, where are you? Unmute, yeah.
Thank you. People have been waiting to do that for me for years. Right. I think the one thing about the Armed Forces Covenant is that it is very misunderstood by many. But I think the most important thing about the Armed Forces Covenant, it is a covenant that requires all areas of public duty and bodies to support the military community through no disadvantage. And that has been integral for, I think, NHS England to look at their work in the past and our work now to the commitment of our serving, and as quite rightly said in that question, I think, transition and also veteran community, where there has been disadvantage because of either their status of employment or ex-employment, or because they have received, or we don't know whether they have, but they need to be assessed, a physical or a mental or a combination of injuries and healthcare needs through their time in that employment as part of the military community. Now, I mean, it is something that I think does get confused because people get concerned that it's about being put at unfair advantage. So what does that mean? Often when someone says, my son or daughter's had a car accident and is an amputee, and then someone from the Armed Forces community is an amputee because of their their serving issues, why is anyone less important? A really fundamental question. As far as the NHS is concerned, everybody should be getting the same level of quality and care because of their clinical need and their clinical assessment, both physical and mental health, and also through primary care. And what I think the Armed Forces Covenant has done, and services like the high intensity services and mental health services for veterans, is actually enabled lots of other parts of the community to also benefit from integrated and collaborative approaches, because ultimately the Armed Forces Covenant is that you, as we said so many times all the way through this, you can't do this on your own. It's about that military and lived experience intervention and collaboration. So I'm sorry, it's quite a long answer, Lord Patel, but it is something that I think is a really important question, but it is still a government national requirement for public sector bodies across all areas, including housing, employment and everything else. And I think it's about, and I will quote Dr. Bashford on this, if you look at it from a protected characteristic point of view in equality and diversity terms, then it's about looking in veterans in an equality and diversity lens. Thank you.
That's actually a lovely sentence to end on there, Kate. Many thanks. Look, clearly we could spend several more hours on this topic. Huge amount of information we've thrown out at people. We've probably not had enough time to have a real discussion about this, but we'll set something up to continue this. Maybe, you know, set another webinar up to bring people more up to speed. I think it's been really helpful. Fantastic range of speakers. Thank you all for keeping to time. My chairing's been terrible, so we're, you know, 5, 6, 7 minutes late. The sun's beating down on my back, so that's been the reason. I hope you all keep safe and well. We'll look at the chat box. If there's something we can get back to you on, we will do. We've got all your details, and, you know, let's keep fingers crossed, and thank you for the hard work that you're all doing, especially at NHS Solent. So David, please pass our thanks on to people there with Maddie and everybody. Thank you. Take care, folks.